Yes.
For the kind invitation to come to this meeting again this year. I think it's an excellent meeting, and Neil and I are both very grateful for the opportunity to be here. Now, I was asked to speak on this slightly unusual topic, but one, in fact, which I covered recently at the International Society of Hypertension meeting just a couple of weeks ago in Sydney, in Australia. And it's really quite an important issue, and that is how we look at treating people as they move across the spectrum of age from young to old. In terms of where we begin, the only thing certain in life is death and taxes, as Benjamin Franklin once said. But in terms of medicine, to put this into context, we should ensure, or strive to ensure, that when people do die, they are chronologically old as possible, but still biologically young. And the relevance of that statement will become clear in a moment. It's the concept of medicine moving to an era of healthy aging. The objective of medicine is not only to prolong life, but to compress as much as possible the morbidity associated with later life. And this is going to become a big challenge, which I think medicine is only just beginning to realize as our populations age and we get the problems associated with aging of infirm elderly and the healthcare costs associated with that. Now, if we look at hypertension, the face of hypertension is changing. For most of the last 30 or 40 years, the focus has been on the ability of blood pressure treatment to prevent acute events which used to occur in midlife. These are acute ischemic heart disease, acute stroke, and premature death in midlife. We've become very good at that, and although we don't prevent all of them, there's no doubt that there has been a dramatic improvement in survival as a consequence of effective blood pressure treatment. And this has led to a complete shift in the disease burden. So now, as we move forward in the next 10 or 20 years, our focus in terms of treating blood pressure is also looking to see whether we can impact on the chronic consequences of hypertension, the emergence of heart failure, particularly heart failure with preserved ejection fraction, which cardiologists at many meetings still argue they don't know the cause of. The cause of it in most patients is hypertension. Systolic heart failure, atrial fibrillation, chronic kidney disease, ultimately leading to dialysis, and really the elephant in the room, dementia, which is going to double in prevalence over the next 20 years in most countries in the world. All of these are miserable consequences of high blood pressure and very expensive consequences of high blood pressure in late life. So hypertension is best viewed, in my view, as a condition associated with accelerated cardiovascular aging. And in terms of treatment, we need to ask the question, when does the aging process begin in terms of high blood pressure? Well, if we look at the profile of blood pressure according to age, we begin to get some clues as to when that aging process might begin. In young people under the age of 40, most hypertension is either diastolic hypertension or systodiastolic hypertension. We see very little systolic hypertension in isolation. As you become very elderly, most hypertension is systolic hypertension. So the pathological profile of blood pressure changes with age, and the hypertension prevalence increases with age. The basis for this isn't the sudden emergence of genetic abnormalities or any other dramatic abnormalities of that kind. It is related to chronic damage to the aorta, which leads to progressive stiffening of the aorta and the emergence of a completely different pathology, which is systolic hypertension, which is primarily related to arterial stiffness rather than classic hypertension in the young, which is primarily related to arterial remodeling in small arteries. So in young people, when you see these patients in clinic, they'll predominantly have diastolic hypertension. They'll have an increased activation of their renin-angiotensin system and also increased sympathetic nervous system activity. Biologically, they'll have an increase in peripheral vascular resistance in remodeling, and already they'll have features of the metabolic syndrome in many cases. So this is the profile of a young person with hypertension. And that profile should give us some clues as to the most effective treatment, which I'll return to in a moment. In the older person, we have a completely different pathology. Systolic hypertension, a wide, both indicative of arterial stiffening, principally in the proximal aorta, compounded by volume expansion related to a declining GFR and sodium sensitivity, and the more dramatic metabolic disturbances, often with the emergence of type 2 diabetes. So when does this aging process begin? Well, actually, it's a longitudinal process in terms of arterial stiffening. Your arteries get stiffer and double in their stiffness. Your pulse wave velocity gets faster as you get older. In fact, your pulse wave velocity is the only thing that gets faster as you get older. By the time you're 80, your pulse wave velocity will be the same speed as Usain Bolt, around about 10 meters per second. And you can see this here. So this process we used to think of as a natural phenomenon of aging, but we didn't realize that this is the harbinger and the basis of a lot of the disease that we see in later life, including disturbances to ventricular vascular coupling, which culminate in diastolic heart failure and ultimately systolic heart failure and atrial fibrillation. Now, this was beautifully illustrated by a group from the United Kingdom at Cambridge, by Ian Wilkinson's group, who looked at young people with hypertension. Now, I don't know whether you have a pointer. Do you have a pointer? There's no pointer up here. In young people on the right with essential hypertension, young age, 20 years of age, you see what I was describing earlier, the classic feature of elevated diastolic blood pressure being the predominant feature of their hypertension. But occasionally, you see this group of young people, only 20 years of age, with isolated systolic hypertension, which we usually associate with the very elderly. And they often have already got the same features of the very elderly hypertension, 146, a higher systolic, and a relatively normal or low diastolic, the emergence of isolated systolic hypertension in youth. Now, the clue to this is the fact that these young people with isolated systolic hypertension, which is abnormal in youth, already have accelerated aging of their cardiovascular system. So there probably is a phenotype of an elderly, accelerated aging phenotype, even in young people, who are best recognized by the emergence of isolated systolic hypertension. Whereas in the others, the pulse wave velocity is normal, cardiac output is normal, and the main reason they have hypertension is an increase in peripheral vascular resistance. So we're beginning to dissect out different forms of hypertension, even in the young, where the dominant form is diastolic hypertension due to increased vascular resistance, but some patients have an increase in stiffness. Now, you might ask the question, when should we intervene in young people to stop them becoming old people in terms of their blood pressure profile? How can we stop the development of isolated systolic hypertension, which is really a disease of aortic aging? Well, this slide is rather depressing, because this is a beautiful study looking at MRI and the functional characteristics of your proximal aorta according to age. And although your pulse wave velocity seems to go up in a linear fashion, in reality, you're losing most of your aortic elasticity by the time you're 40. So if you have hypertension and you haven't been treated by the age of 40, you will get systolic hypertension, and you will get more resistant hypertension due to damage to your aorta. Most of the damage is already done by the time as to when we should be intervening with these people and how aggressively we should be intervening. Another important point about the aging process is that when you're young, although your brachial blood pressure systolic might be high, some of it can be spurious due to amplification of pressure from the aortic root. So we're finding some young people with systolic hypertension who don't have stiff aortas, haven't got accelerated hypertension. In fact, when we measure their aortic pressure non-invasively, they don't even have hypertension. These are paradoxically healthy people due to this amplification process, which is usually indicative of aortic health. However, as you get older, what you measure in your arm is increasingly close to what is going on in your central aorta. So another feature of the aging process is a reduction in amplification of aortic root pressure to the brachial artery, so that your artery pressure in the arm is almost identical to the artery pressure in your aortic root. Now, why is this important? It's important because people who are older with hypertension have much higher real pressures in their aortic root than people who are younger. So we underestimate the true hemodynamic effect of hypertension in the very elderly, because paradoxically brachial pressure somewhat underestimates aortic pressure as you begin to get older. So aortic systolic and pulse pressure are disproportionately high relative to brachial pressure in very elderly people. Now, there are a number of mechanisms responsible for this biological aging of your aorta, as illustrated on this slide, many of them accelerated by diabetes, smoking, and hypertension itself. But actually, there are only two things that are really important in determining how fast your aorta will age from whatever age it is set at when you're in your 20s. And that setting may be genetic, but we still don't know the true reasons for that. Basically, the two key factors accelerating your aortic aging are age itself, as a cumulative index of exposure to the other risk factor, which is your blood pressure. So if you are hypertensive when you're young, you will get accelerated aging of your aorta, you will end up with a faster pulse wave velocity, and you will end up with more severe systolic hypertension. Now, why am I talking so much about the young? Does blood pressure really matter that much? Now, for many years, guidelines have said very little about how to treat young people, mainly because we've lacked evidence about the true prognostic value of blood pressure in young people and what level of blood pressure is biologically important. So this comes from a massive study in Sweden, looking at 1 million people conscripted into the Swedish army. Now, the Swedish army records the blood pressure of everybody who joins when they join the army. I don't know what else the Swedish army does, but that's one of the useful things that it does. And we can see here the relationship between blood pressure and all-cause death in young men. So these were 18 when they had their blood pressure measured. Follow-up was about 35 years, and they have these extraordinary registries in Sweden, cap of everybody. And interestingly, if you look at the level at which risk begins to increase, both for systolic and diastolic blood pressure, it is about 140/90. That is the level at which your risk of subsequent cardiovascular death in years begins to increase quite dramatically from the age of 18. If we look at all-cause mortality, we see exactly the same threshold phenomenon, both for cardiovascular and all-cause mortality. So from that point of view, we should certainly be thinking about treating young people once their blood pressure is 140/90. And I summarized this in an editorial I did on this paper for the BMJ when I said, it's easy to stratify risk in old people because we have data from intervention trials showing the benefits of treatment. But stratifying risk in young people is more complex and ultimately requires more detailed study of the consequences of blood pressure on structure and function, which are the recognized harbingers of future risk. Further studies are really needed to define how best to stratify very young people for treatment with raised blood pressure, and it's quite probable that those with already evidence of stiffening of their arteries should be treated even earlier and at a lower threshold. Now, the final thing I'll say about the young is considerations of treatment. In terms of vascular damage, we know that small artery remodeling can be reversed if it's treated early. We know that from many trials and indeed human trials. But we also know that once your aorta is damaged in terms of its profile for stiffness, then it cannot be reversed. In terms of cardiac damage, we know that the muscular hypertrophy of the heart can be reversed. But cardiac fibrosis is probably not reversible, and certainly diastolic dysfunction looks to be non-reversible and non-treatable at the moment in terms of outcome. If we look at the brain, small vessel ischemic damage is not reversible, and neither is cognitive decline, which probably begins from about the age of 40 in people with hypertension. In terms of the kidney, albuminuria is reversible, glomerulosclerosis is not reversible, and the decline in GFR can be delayed but is not reversible. So the priority in people who are young enough to be detected with hypertension has to be to treat them early and try and prevent the disease. Here in JACC, from a paper I wrote on this subject, hypertension in the young, the cardiovascular consequences of hypertension here, then we really appreciate it. The onset of systolic hypertension should be regarded as indicative of established arterial disease. This is a prelude to an inexorable rise in systolic pressure towards more resistant hypertension and the chronic cardiovascular, renal, and cerebrovascular disease in the young. We detect blood pressure and we treat it too late. The best way to treat hypertension is to prevent it developing, at least in terms of systolic hypertension, and we need to go away from this meeting and think more about treating young people earlier. Now, what about the feasibility of treating young people earlier? There's only been one real study in this area, and this was the study here, the trophy study published in the New England Journal of Medicine almost 6 years ago, but has never yet been replicated or extended or expanded upon. This looked at using an angiotensin receptor blocker to see if it could prevent the development of hypertension. The design was simple. These were all people with pre-hypertension under the age of 50. They were given either placebo and lifestyle advice, which you can see was pretty hopeless, that by 2 years, 50% of people with pre-hypertension given lifestyle advice had developed hypertension. Angiotensin receptor blocker had a very much reduced likelihood of progressing to hypertension. Unfortunately, once the treatment was stopped at 2 years, the hypertension then began to emerge. So this suggests that we can prevent the emergence of more severe hypertension by treating younger people early, but once they start treatment, they need to stay on it because it's unlikely to prevent disease. I like this quote from Shakespeare. I don't do much culture, but this one summarizes quite nicely, I think maybe was the first description of the early treatment of hypertension. A little fire is trodden quickly out, which being suffered, rivers cannot quench. In other words, if you don't do it early and easily, then you'll have much bigger problems in dealing with it later. And that's what we know from delayed treatment. So what have we said on the basis of evidence about how we should treat young people in my country, the United Kingdom? Well, basically in the young, what we've said is under the age of 55, we should generally start with a drug that blocks the renin-angiotensin system for a number of reasons, many of them pathophysiologically derived rather than clinical trial-based, simply because there have been hardly any trials. Firstly, RAS is activated in the young. RAS blockade is good at structural regression, and RAS blockade is metabolically neutral, and RAS blockade may also protect the aorta. If that doesn't work, we've recommended the addition of a calcium channel blocker because that is metabolically neutral and easy to use in young people. And if that doesn't work, we'd give them a diuretic. So that's our strategy for the treatment in young people. Now, quickly, the elderly. Now, they have a completely different profile of hypertension, as I've mentioned. They mainly have systolic hypertension. And as I've suggested here, this is really the consequence of delayed or poorly treated hypertension in most patients. Now, treating the elderly becomes more difficult if we wait. There's progressive stiffening of the aorta. There's reduced buffering of stroke volume and a widened pulse pressure, and more difficult to treat systolic hypertension.
There's a declining diastolic blood pressure as well, which is a concern, and isolated systolic hypertension. This is compounded by the fact that many of these patients are already developing renal impairment. Many of them have got abnormal baroreceptor function and fall over if you treat blood pressure too aggressively. And many have comorbidities, and so already on many drugs, which makes treatment quite difficult. Now, there are differences in drugs in the elderly. This is one of the studies we did looking at aortic pressure, which I mentioned earlier is disproportionately high in the elderly. Basically, it looks like beta blockers and amlodipine-based treatment in the ASCOT trial, of which this was a sub-study, were quite similar on brachial pressure. But beta blockers were hopeless at reducing central aortic pressure. And the best drug for doing that was amlodipine in combination with a RAS blocker, an ACE inhibitor in this case, which reduced aortic pressure most effectively, and in the main trial was more effective at preventing cardiovascular events. And this was replicated in another study, where a beta blocker was given with a calcium channel blocker compared to a RAS blocker, in this case an ARB and amlodipine. And again, the brachial blood pressures were the same, but actually the aortic pressures were better protected by not using a beta blocker, but using a RAS blocker in combination with a CCB. And one of the reasons is beta blockers lower heart rate, and that doesn't make you into an athlete. Unfortunately, lowering your heart rate when you're elderly simply increases your pulse pressure and increases your systolic pressure and makes your blood pressure more difficult to treat. It compounds the problem of aortic stiffness. It is a ridiculous treatment to give to elderly people. We should not be lowering their heart rates. That's why in our country, since 2006, we don't give them beta blockers. And you'll have noticed this week in JAMA, the Americans have also now realized that beta blockers not only are less effective at preventing stroke, but they don't prevent coronary disease either as primary prevention. The second issue in the elderly is they have stiff arteries and they have increased blood pressure variability. And as Neil and his group demonstrated in the ASCOT trial, whilst calcium channel blockers, by lowering blood pressure, were very effective at reducing blood pressure variability, beta blockers were a disaster. They increase blood pressure variability, which in itself is independently associated with risk of stroke. So for all these reasons, in the elderly in our country, we believe the most effective treatment for the elderly, if you had a single drug to choose, would be a calcium channel blocker. The asterisk means that if you're over 75 and at increased risk of heart failure, a diuretic might be preferred. And if that doesn't work, which it won't in most, we would combine that with a RAS blocker. And if that doesn't work, we would then add in a diuretic. So you can begin to see how our treatment strategies are pathophysiologically based. So just the final statement is about the very elderly, people over the age of 80. The best data for this came from the HYVET trial, which used indapamide as the baseline treatment. And this study in the free-range very elderly, this is quite irritating because it doesn't move on. Can you move on? Produced a 30% reduction in the risk of stroke. Again, a 39% reduction in death from stroke. A 21% reduction in death from any cause. A 23% reduction in death from cardiovascular causes. And a 29% reduction in death from cardiac causes. A 64% reduction in the likelihood of being hospitalized for heart failure, and importantly in this very elderly group over the age of 80, fewer adverse events in the actively treated group. So NICE in its guidelines said, new evidence suggests, primarily from HYVET, that blood pressure lowering reduces the risk of stroke and heart failure and death in people over the age of 80. So we should also be offering these people the same treatment as those over the age of 55, that's a calcium channel blocker or a diuretic. But importantly, we should initiate treatment over the age of 80 when people have stage 2 hypertension. That is when their blood pressure is above 160 systolic, primarily, as most of them will have a normal diastolic. This is because we don't know whether it's safe enough to continue to lower blood pressure above that level, below that level in the very elderly. And the target in the very elderly is also more cautious. This is over the age of 80 at 150 over 90. Now, my last slide will deal with an issue that will come up in questions. What about the low diastolic pressure? Cardiologists have got very worried about this. The important message here, there's been a lot of rubbish written about the so-called J-curve for diastolic pressure. Low diastolic pressure, as I've shown you, equals arterial disease. The reason they have a low diastolic pressure is because they've got disease. And people with low diastolic pressure have more events because they've got disease. And it's not because they've got a low diastolic pressure, but because they've got a high systolic pressure and a high pulse pressure and a high central pressure, which is the thing that drives the disease, not the low coronary perfusion. The best data on the clinical benefit of hypertension is actually in people with isolated systolic hypertension. So we said you should not be worrying about diastolic pressure in the elderly. You should be treating the systolic pressure, as that is the thing that will reduce cardiovascular events. So in conclusion, the disease burden associated with hypertension is changing as a consequence of the more effective treatment of cardiovascular risk factors in midlife. The future focus should be on more effective strategies to actually prevent the chronic insidious damage that culminates in later life development of heart failure, kidney disease, and brain disease. And this will require a policy shift towards focus on the earlier detection and treatment of hypertension in our populations. As I said at the beginning, in medicine, we should be striving to ensure that when people die, they are chronologically old, but hopefully as biologically young as possible. Thank you very much.
I request Dr. William to join the panel. I start the discussion with a question to Dr. Williams to start with. So the central blood pressure, central aortic pressure and the brachial pressure difference is high in elderly and almost normal in young?
No, the other way around. There's a big difference between your central pressure and your brachial pressure when you're young. In some young people, it can be as much as 30 millimeters of mercury systolic. So some young people can have a systolic pressure in their arm at 150 and an aortic root pressure of only about 120, which is just at the upper limit of normal. So we think that in the young, some people might be spuriously labeled as being hypertensive based on the amplification, which paradoxically is a healthy phenomenon. However, this is a relatively small number of young people. In the elderly, what you measure in the arm is pretty close to what's going on in the aorta, which tells you that the aortic pressure is actually much higher in the elderly.
Any question from the floor?
What would be your question to Dr. Neil Poulter? What would you, where would you put the spironolactone into the armamentarium of diuretics in treatment? Because primarily we have seen that spironolactone as a diuretic is very useful in the resistant hypertensions, especially when you give 2-3 drugs, the patient doesn't respond. That diuretic of, if you add spironolactone, we have seen the blood pressure responding extremely well. Now, what would be your comment on that?
Well, that's exactly when I would recommend using it in resistant hypertension. If we take the definition of resistant hypertension as being on 3 drugs at maximal dose, or at least maximum tolerated drugs, and the 3 drugs that we recommend in Britain are an A, C, D. So you'd have RAS blocker, a calcium channel blocker, and a diuretic, which would be andapamide or chlorthalidone. If that fails, you then could be adding in the other drugs. I personally tend to use doxazosin 4th line, and then I turn to spironolactone. In the Ascot trial, spironolactone was used 4th line, and it is in that setting when you get this fantastic 22/10 reduction as a 4th line agent is brilliant. So it's when it's resistant hypertension. Why not use it earlier on? Well, I think the evidence to do so isn't so clear, but I think you have to bear in mind that spironolactone is associated with gynecomastia. You've got to watch the potassium. So whilst it's at low dose, you can use it with impunity later on. I think there are concerns about its use, so I tend to use it later on in resistant hypertension.
You think the drug eplerenone has a role because could that exactly replace Spironolactone?
Eplerenone is less effective, again, dose for dose. So if you're using 25 of spironolactone, you'd need at least 50 milligrams of eplerenone to get the same blood pressure lowering. The benefit is that you don't get so much gynecomastia. It doesn't have the same evidence for use in hypertension. Of course, it's more expensive. So I think if you get gynecomastia with spironolactone, then turn to eplerenone, but you'll have to use a bigger dose.
Yeah, I would agree. The only thing I would say about eplerenone is that we did a study in people with hyperaldosteronism, so we were targeting aldosterone, and we found 100 milligrams of eplerenone was about half as effective as 25 milligrams of spironolactone. So in terms of lowering blood pressure, I think dose for dose, it's about a quarter as potent as spironolactone. And that may be one of the reasons why it doesn't cause gynecomastia, because it's simply much less potent as a drug.
Ruling out.
Palter, thank you for a splendid lecture. And having listened to you and being convinced that diuretics is different from those who are not thiazide diuretic, how come that drug companies still produce combinations, fixed combinations, with ARBs or ACE inhibitors and actually thiazide diuretics?
Lars, a very good question. It's very, and that history, that historical practice is carried over and is still carrying on. You're absolutely right. The companies have always done that. I think from a technical point of view, logistically, it's been easy to do that. And low-dose thiazides were, 15 years ago, the diuretics that we favored. So it's just taken over. Don't know whether technically adding in chlorthalidone and indapamide is so difficult. I can't imagine that it is. But I think we should be moving towards doing. But there's a big problem because that history will carry over.
And Neil, the other interesting thing about it was that when the early studies were done with the high-dose thiazides, and they got some efficacy high-dose thiazides on outcomes, when the combinations were developed, the drug company problems with sodium, depletion of sodium and potassium, and simply reduced the dose of the high-dose thiazides and created this notion of low-dose thiazides. But actually, nobody ever asked, actually, do they?
Sugar, but to get them to lose weight. So that's a disadvantage is nausea, especially the first few months, and there's a heart increase of about 4 beats per minute. No, that makes it simple. Weight control. With metformin tablet.
On this oxide rests and CV risk biomarkers, BMP loss, it means 4 kilos, and the difference goes in with glycogen and increase of waist, but clearly of which is
a difference between people who have normal adiposity and good habits. And those people have got no ectopic fat.
And there are many special issues, recently an issue of IJE, which summarized this. What is epigenetics? Epi means upon and genesis is generation, but epigenetics basically means it is something which acts over and above the gene. So this single molecular biology dogma that a DNA change would be associated with protein change is a bit challenged, that there are some additional factors involved here. The term was first coined by Waddington in embryology as saying that studies which explain the causal interactions between genes and their products and which bring the phenotype into being. So he described how sperm meets an ovum, and from that point into the development of an individual which is delivered, all the processes which occur, he called them epigenetic. Recently, we now call it, these are heritable changes. That means they are transmitted from one cell to other cell, especially by mitosis. while the usual genetic changes are transmitted even during meiosis. These are usually transmitted during meiosis, except for a few which mitosis, except for a few which go during the gametogenesis. And these are not attributable to sequence variation like what I shown before, like say a base change pair. It's not a base change pair, but these are changes, chemical changes in DNA which are transmitted and not due to the sequence variation. Now, there are classic examples which have been described before of epigenetic changes. In reptilians, the gonads are bipotential, so that they can develop either into male or female. And the stimulus is the temperature which surrounds the eggs. So if the temperature is warm, that egg develops into a female, that means the gonad becomes ovary. If temperature is cool, it develops into testes and male. So when there is a mound of eggs in an amphibian sort of place, then the central eggs hatch into a female while the outside eggs hatch into a male. Same genome, environmental action, temperature, different phenotype, that's an epigenetic change. This is Drosophila, which is again a geneticist sort of friend. If the surrounding temperature of the embryo is briefly raised from 25 to 37 degrees, instead of white eyes, that fly gets a red eye. And this is not due to a genetic change, it's just a chemical modification because of temperature. And when this fly is crossed with a white fly, the many generations are partly red-eyed. That means it's transmitted across the generations. It's not a mutation, it's not a polymorphism, it's an additional chemical change surrounding the DNA which is transmitted. And this, of course, has now, reawakened the Lamarck versus the Darwin's theory of evolution, where Lamarck said that an inherited or acquired trait can also be inherited, which was ridiculed for hundreds of years. And Darwin, of course, talked of mutation and a natural selection. What's very important is this usually is thought to take thousands, if not millions of years to get selected and established in population. This can happen in one generation and can establish for a few generations. The classic example, which we all know, but we don't know it's epigenetic, is the lionization. This we learned in our early days as medical students, that women have two X chromosomes, and one of them is randomly inactivated during embryonic development. And this random inactivation creates women to be a mosaic. So all women are mosaic. And this random sort of inactivation is usually by process of methylation and by process of synthesis of RNAs, which are called iRNAs, which are small, non-translatable RNAs which have a regulatory function. And this, of course, is the description from Mary Leon. So the epigenetic mechanisms which are now known to operate, the major one which is studied is DNA methylation. There are areas in DNA molecule which are called CPG islands. That means cytosine and guanosine are adjacent to each other. And there the cytosine gets methylated, and that means the transcription factor which transcribes the gene cannot interact with that part of genome. And these CPG islands are usually in the promoter regions of the genes. Therefore, once the promoter region of the gene is methylated, that gets silenced. If it's not methylated, it becomes active. And that is how a gene is either expressed or not expressed. And methylation is the chemical change. Histones, which are surrounded by DNA in the chromatin, can again get modified by various chemical processes. At least 5 have been described. The commonest one is acetylation. And when that happens, again, that part of the genome cannot be transcribed because it changes the secondary and tertiary structure of the genome. So simple chemical changes either in the DNA itself or in the proteins which are associated with DNA can modify the expression of the gene. And this gets very interesting because even if you have a polymorphism or a mutation, if that gene is methylated or the histones which are associated are acetylated, it will not be expressed. On the other hand, when that process or that methylation or acetylation is removed, it will be expressed. The RNA-mediated gene silencing is a relatively new phenomenon. It won Nobel Prize actually a few years ago, and these are called miRNAs. It's one of the mechanisms of the X inactivation which we saw. And as I said, these changes have some mitotic retention. That means during mitosis, they can be transmitted from one to the other cell. Now, the central dogma becomes more complicated, that in addition to genome, there is now an epigenome. Then it gets translated, that is called transcriptome. Then proteins are synthesized, that becomes proteome. And then there are metabolic groups of molecules which we call metabolome. And therefore, environment acts at all these places, but especially here on the genome, converting the genome into epigenome. Now, various examples are given. I have recently attended 3 workshops on epigenetics because we are now getting into this research. One was organized by Caroline Relton in Newcastle in the UK recently. She gave this very nice idea that DNA is like the map. That's the blueprint. That's what actually you read. But when you start traveling on these roads, then there are various post or road post signs. And these are either the methylation or the acetylation or the phosphorylation of various other markers which we talked about. So depending on these, it directs the flow of traffic along the main sort of roads on the map. If there are problems with this system, like you can see here or you can see here, then that creates a tremendous disturbance in the traffic. So even though the roads are there, the maps are there, change in the road sign maps, or if someone turns it other way around, can actually cause a whole lot of disturbance to the gene expression. And this is what the epigenetic changes are. So the final phenotype which we talk about is between genetics, including the SNPs and mutations, epigenetics, which involves various chemical processes, and the interaction of environment with these processes, which might be either nutrition, toxin, pathogens, drugs, etc. And that's the central phenotype here. And as so you can imagine a fusion of a sperm and an egg produces a fertilized ovum. But from that one cell, we get the whole organism with millions of different cells, and that is where epigenetic changes suppress or activate certain genes, and that's how each organ develops. That's mitotically transmitted, and that's how that organ develops. Aging is supposed to be an epigenetic change where epimutations are accumulated over years, and there are disturbances in the expression. Cancer is actually the best known example of epigenetic changes accumulation. And most of the research over the last 30 years has been shown in cancer, and various markers are now known where certain genes can be activated or silenced, and when the number accumulates, that expresses as carcinogenesis. 2 things which I'm not going to talk about today, but diabetic complications and atherosclerosis are now looked upon as accumulation of epigenetic changes. And there are very beautiful works on this, which show that accumulation in presence of either hyperglycemia, hypercholesterolemia, or a combination of dyslipidemia leads to various epigenetic changes, let's say in the endothelial cell and the vessel wall, causing the problems. There is a human epigenome project now run from Sanger, And there are a number of other programs like methylome project, acetylome project, etc., which follow the pathways which the human genome progressed. And it's interesting to know that within a short time, all the epigenetic marks are completely removed and then re-established. And there can be a number of problems at this time which can lead to a number of problems which express later in the life. And this could be one of the bases how intrauterine environment, especially periconceptional environment, can affect the future phenotype. Intergenerational epigenetic programming is what interests me the most. And that means intrauterine environmental factors, which include a whole lot of them, affect the developing fetus, change the gene expression, and as we said, that's mitotically transmitted. It remains with you for the rest of the life. That's what we call programming. And that's how various conditions might also be partially epigenetically programmed. The major mechanism we said is methylation, and methyl groups come from dietary methyl donors and cause methylation of DNA. This is the methyl cycle where the dietary factors which regulate it are folate, vitamin B12, vitamin B2 and B6, choline, betaine, methionine, and zinc. These are very common dietary items which actually determine the balance of methyl cycle, that means the SAM versus the SA, which in turn stimulates the DNA methylation enzyme in the CpG islands into the methylated CpG islands. So diet can have a profound effect because of the methyl donors. Great example of this was published in 2003 from Duke University by Rob Watland and Randy Yirtle. You know this mouse perhaps? This is a yellow colored mouse called agouti mouse. And agouti mouse is genetically. What they did was they fed the pregnant agouti mice with lot of methyl donors, and the offspring changed the coat color and became less obese despite inheriting the agouti mutation. And molecular biology showed that the whole thing was due to methylation in the promoter region of the agouti gene in the offspring. So first example that pregnancy diet can alter the obesity and the coat color in the mice. And even more elaborate sort of model was set up in Nottingham University in the UK, where sheep were kept on a methionine deficient diet, and that led to a gender-specific increase in insulin resistant, glucose intolerance, higher BP, and altered immunity. And they could find 57 regions in the genome where epigenetic changes had occurred. No genetic changes, only epigenetic changes, change in gene expression, change in the phenotype of the offspring. You know, Pune maternal nutrition study, we found that maternal green leafy vegetable consumption, milk consumption influence the growth of the baby. We also found cell folate concentrations were a strong determinant of fetal growth. And in addition, maternal homocysteine concentrations were a strong predictor of intrauterine growth restriction. Low maternal B12, adiposity, and insulin resistance in the child. And we suspect this is epigenetic. Another example is Dutch winter hunger, where women were fed very low calorie diet towards the end of the Second World War, when Germans cut off the food to the Holland. So on that very low 400 to 600 calorie diet, children who were in utero in the third trimester at that time were less obese, while in first 2 trimesters they were more obese as army conscripts. And this was supposed to be epigenetic regulation of adipocyte number and hypothalamic appetite programming. And now we have a whole lot of epigenetic studies which have been done in the offspring, starting at birth in cord blood, during infancy, during childhood and adult in relation to a whole lot of exposures in the intrauterine period, showing alteration in methylation of number of genes and change in the expression. FTO is a gene which is associated with, it was described by Andrew Hattersley and Tim Frey. They showed that in Europeans, FTO, which was found on the genetic association of diabetes, acted through BMI. So that when the association was corrected for BMI, the diabetes association became non-significant. We replicated these studies immediately, and we found FTO strongly predicts diabetes in Indians. But when you adjust for BMI, it doesn't get rid of the diabetes association. And I suspect this may be due to a large number of low birth weight babies in our cohorts, which were probably epigenetically regulated during their intrauterine life, so that they did not get the BMI, but this phenotype expressed. And we are now working on FTO gene methylation in our population. And finally, I'm going to tell you that we have now started what's called Pune intervention study, which is in hypothesis to regulate the epigenetic regulation during the sperm and ovum development in adolescents, so that we are treating adolescents with a multi-micronutrient supplementation, and we will study their newborns for a whole lot of measurements, including their birth size and a whole lot of genomics. And it's again the first study of its kind to use a methyl donor in a preconceptional diet to alter the risk of diabetes and obesity in the next generation. And we are going to couple that with a whole lot of omic studies in collaboration with institutes in India, which will look at metagenome, which is microbiome, methylome, transcriptome, metabolome, immunophenotypes, and we are going to develop an animal model. So why did I call it emperor's clothes? So I think basically DNA and epigenetic changes can be looked like clothing for the DNA. So the DNA remains same, but when it puts on different dresses, the expression becomes different. And final slide is that when one of the, like say mornings I was traveling in Paris for attending a meeting, I found they have this chain of B12 stores. That's quite amazing. I never thought there would be a B12 store anywhere in the world. And that sells masculine dresses, so clothes for men. I think French had connected the B12 methylation donor potential, the masculinity, that means the lean mass versus the adipose mass, much before any of us found it out. Finally, acknowledgements. For this part of study, we have strong collaborations with the MRC Life Course Epidemiology Unit in Southampton, Peninsula Medical School, Exeter, Blizzard Institute in London. We are funded for these 2 by 2 EU projects, and we have a whole lot of collaborators in India. And my gurus in this have been Helga Repsam and David Smith from Oxford, been funded by various organizations. Thank you.
Thank you so much for a most fantastic lecture, bringing us into a future perspective, which is just hilarious and fascinating. Considering what we have discussed here today, I would also like to congratulate you for having had the ability to join the best possible resources from Europe with India. These studies that we are talking about now and the perspective you bring to us would be possible without you having that collaboration, just showing that the best out of India with the best from Europe will actually bring knowledge to a brilliant future. And I wish you good success with this, because this is indeed pioneering work of a sort that you seldom hear about. So thank you so much. Sorry? Yeah, where do we have the program? So, no, it's wrong. Here we go. So the next issue to announce now is to ask Neil Poulter to the podium and talk about hypertension.
Ladies and gentlemen, thank you very much. In this session, I'm just going to discuss some of the links between hypertension and coronary artery disease. This slide links or lines up the top numbers of death around the world currently. And the top of the list is high blood pressure, whether from high income, middle income, or low income. The biggest single risk factor is systolic blood pressure of 115 and above. Next slide, please. High blood pressure kills us two ways mainly, through ischemic heart disease or coronary artery disease. And the steepness of this slope on the left, this is stroke stratified by age with increasing pressure, indicates the fact that that associative cause, that link, is stronger than it is for ischemic heart disease, shown on the right. But in terms of absolute numbers around the world, high blood pressure kills through ischemic heart disease more so than it does through stroke. Next slide, please. If we turn now to the burden of disease, there's different regions of the world. So this is East Asia and the Pacific, Europe and Central Asia, Latin America, the Middle East, South Asia, Sub-Saharan Africa, and high-income countries. And it shows you these disability-adjusted life years. So it's the burden, if you like, of the disease in these different parts of the world. The pale blue is stroke, and the dark blue is ischemic heart disease. And this is how blood pressure exerts this burden on the world. And you can see, depending on where you are, it's between stroke and ischemic heart disease. Far East, stroke dominates over coronary disease, but in Europe and Central Asia and in South Asia, coronary artery disease dominates in terms of its impact, in terms of global burden. Now, what's worrying is if we look at the top here, this is 2000, 2025, men in blue, women in red. These are the different 8 regions of the world, World Bank regions. And you see here, if you go from 2000 to 2025, the problem of hypertension expressed in millions of people is going to increase. Wherever you are, those numbers go up a big time. So the biggest single is going to increase in terms of absolute numbers in a large amount over the next 1 or 2 decades. Putting that simply, as of about the year 2000, there are estimated to be 1 billion hypertensives, but by 2025, that will have gone up to over 1.5 billion hypertensives. Now, that's in part and largely due to the fact that the world is getting older, increasing in numbers, but it's also due to the fact that most of the world is developing. About 80% of the world are perceived as developing. And when populations develop, they get older, they exercise less, they drink more alcohol, they have more salt, they eat less fresh fruit and vegetables, so potassium intake goes down, body weight goes up, stress, well, I don't know. My belief is just changes from one type of stress to another. Smoking goes up and saturated fat intake goes up. You don't have to be an eminent medical audience such as this to realize that if that happens to 80% of the world, then cardiovascular disease is going to increase. And indeed it will. And for lots of the reasons shown here, high blood pressure will increase. This shows the association between age, this is years along here, and systolic blood pressure. And what we expect typically is for blood pressure to rise with age like that. That is usually in the westernized or modern world. But actually that, shown there, is normal. Once you get to full adult maturity, blood pressure should not rise with age. It should be at the same level. That is the normal situation. That is the result of pathophysiology, which has got nothing to do with your genes. It has everything to do with the environment. There's all those features of development that you see. Lack of exercise, increasing body weight, increasing alcohol, all those things, it is that which drives this abnormal pathophysiology, which makes blood pressures rise with age. But that is the normal situation, which without the environment would always be the case. We have no genes, except one, which is exquisitely rare, with hypertension without the environment. It is out that the genes do not express themselves without the environment. One exception, which is exquisitely rare in the field of hypertension. So, here we have a problem. The blood pressure is going to go up around the world, and those risk factors you expect are going to go up around the world. And so here you see the 8 regions of the world, 1990 in blue, 2020 in green. These are thousands of deaths, ischemic heart disease, and you see the big increase. Wherever you are in the world, there's going to be a big increase. Now, if we turn now to treatment, how reversible is this problem? Well, as of the early 1990s, we could see T is for treatment, C is for control. This is 17 randomized trials with morbidity and mortality. You see that stroke was reduced by about 38% by treating systolic blood pressure modestly by about 11 millimeters of mercury. Coronary artery disease was reduced by about 16%. Vascular deaths down by 20%, and other deaths were unaffected. So it didn't do any harm, treatment. It did have a big beneficial effect on these major vascular events. This rather less than we would hope from the epidemiology, perhaps reflecting the drug types that were used as of the early 1990s in amongst these trials. More recently, if we look at the blood pressure trialist collaboration, each of these are different comparator drugs used to lower blood pressure, and these along here you see the systolic blood pressure difference achieved. So this was comparing A with B. You get an 8 millimeter difference in systolic blood pressure associated with about a 25% reduction in coronary heart disease death. And indeed, if you look now for your 10 millimeters of mercury difference, we're getting rather more than we had with the original early 90s meta-analysis, where it was about 16%. And I think this supports the idea that this may well be about the better drugs that we are using these days. So other benefits beyond blood pressure from our antihypertensive agents? Well, the conclusions several years ago from the blood pressure lowering treatment trialist collaboration was this: the size of blood pressure difference between random groups was closely associated with the reduction in risk. I just showed you that for coronary heart disease. And the size of blood pressure reduction appears to be more important determinant of outcomes. So most of it is down to how much you lower the blood pressure. But here are some data looking at the impact of ACE inhibitors on coronary heart disease death. And these are all different trials where they used an ACE inhibitor. This shows the blood pressure differences achieved. If you go to 0 blood pressure difference, you see here the line of regression actually is below and significantly below 1, implying that there are benefits beyond the blood pressure reduction achieved from these drugs, the ACE inhibitors, over and above what you get from the blood pressure reduction. On the right-hand side, calcium channel blockers, no such effect. The line of regression straight through zero, so no blood pressure difference, no benefit in terms of coronary disease. Interestingly, look the other way around at stroke, got a significant reduction in stroke deaths. On the other hand, that was not true for ACE inhibitors, regression going straight through the no-gain line, implying that calcium channel blockers may have benefits beyond blood pressure for stroke, and that ACE inhibitors may have benefits beyond blood pressure for coronary disease. And that might explain why the ASCOT trial was so successful when they combined an ACE inhibitor and a calcium channel blocker to get benefits over and above the blood pressure reduction, the additional blood pressure reduction they achieved in the trial. That brings me on to blood pressure variability, and this might be rather tangential to hypertension and coronary artery disease. It wasn't on the program, and it seems to me this is something that's potentially massively important for the management of high blood pressure. Rarely do you get 4 papers in one weekend in the Lancet and Lancet Neurology about the same subject, but Rothwell managed it. And just to give you an idea what happened, what Rothwell did was to look at long-term variability, visit-to-visit variability. So over 5 years, how much did the blood pressure vary? You can measure it all sorts of ways, doesn't matter. And then in a relatively smaller group of 2,000, they looked at 24-hour blood pressure and looked at the variability within a day. Then the trial, the patient sat down, we measured the blood pressure 3 times at one visit, and looked at the variability within that visit. So variability, long-term over 5 years, 24-hour variability, and then within a visit. And then we used statistical analyses to look at the associations between this variability, different sorts of variability, and the average blood pressure, just the average blood pressure in the trial, and subsequent vascular events. And then when we looked to see with that association, did that explain why in the trial amlodipine perindopril was better than atenolol thiazide? The summary of those analyses were that mean blood pressure throughout the trial wasn't a great predictor of cardiovascular events, coronaries or strokes. But various measures of visit to visit, how much blood pressure went up and down in 5 years, was the best of any blood pressure measurement that was taken. Variability, it turns out, was linked with age, diabetes, smoking, and vascular disease. But maybe through the alloxan, so getting rid of the insulin secretion, now the tumor size is much lower. So suggesting that insulin may play an important role here. And it's not because insulin is an anabolic mitogenic hormone. Insulin may act through the receptor and through the level of the insulin responses, but also it may activate it through the MAP kinase pathway, the mitogenic effect that is cell proliferation.